usually have, oh, we are live, so I'm gonna stop myself there. Good morning, everyone. I'm Felix Rivera with from Aging Advantage, and this is keep forgetting which educational series we're on. This is part of our Family Caregiver series. Aging Advantage is a local nonprofit in the St. Louis area. We work especially with SLAE, the St. Louis Area Agency on Aging, and they've graciously provided funding for the series focused on topics that would be particularly helpful for family caregivers. And so today we have with us Joshua Bennett from Accent Care. And Joshua, is there anything else you'd like to add to your introduction or?
No, I appreciate the opportunity to be here. Hospice is quite often one of the misunderstood um, parts of the care continuum. So I'm excited about talking through this with everyone.
Yeah, and sorry, as Joshua explained, the topic today is hospice care and palliative care and demystifying that process. And yeah, let's just jump straight into it.
I appreciate it. Thank you very much. So, as was mentioned, my name is Joshua Bennett. I'm with Accent Care Hospice in Palliative Care, Missouri, located in St. Louis. And probably one of the biggest things that I'm very passionate about and that my organization spends a lot of time on is helping just to educate the public at large. That includes both individual patients, family caregivers, but also the medical professionals on what is hospice and what is palliative care. So I think that's a really great place for us to start.
Okay.
So Medicare defines palliative care as human or person-centered care designed to treat suffering in all of its forms. And you might think, well, isn't that just healthcare? And it is, but it's also a little bit different in the case that our current healthcare system is actually designed with diseases at its center, not people.
Mm.
Now, this is for very good reason. The reasons include that, if you come to the hospital or you go to the ER and you're needing urgent medical attention, they want to understand what your needs are. So they classify you. You're a heart patient, you're a lung patient, you're a neurological patient. Maybe you've had a bone break, maybe you're a cancer patient, right? And it's all done for the sake of being able to quickly understand what these patients or individual needs are and how to best support them. And that's why if you ever work or go to a hospital today, they actually categorize and organize their hospital with this same functionality, which is disease-centered care. So you might go to one floor and that floor is an entire oncology floor or cancer floor. Or you might go to one floor and it's a heart or lung floor, right? So all these systems have been created with diseases at its center and not necessarily people. So palliative care oftentimes takes a more holistic approach in how we support patients, not only relying on things like medication or surgical interventions, but also helping individuals to overcome any other suffering that they may be incurring. That could be emotional, spiritual, mental. All these things add up to overall wellness and well-being. And that is the core tenet of palliative care. The way that differs from hospice is hospice includes many more benefits. It is also the core component of palliative care in that it's a human or person-centered care model, but it's specifically designed to help support individuals with all of their needs in the final 6 months of life. So palliative care is a specialty and hospice is a specialty, just like someone would go to a cardiologist or a pulmonologist to get specialized care for their condition or disease that they may be suffering from. So while palliative care uses a specialty in an outpatient setting, it can be done at any time in a patient's care continuum or plan of care. So quite often, individuals will seek out the help of a palliative care professional while they are still undergoing curative treatment for things like maybe a cancer diagnosis or heart failure or kidney disease. And so it's basically seeing another specialist who's going to take a more holistic approach, a human or person-centered approach to your care. And it gets billed and reimbursed by Medicare and insurances the same way any other specialty clinic or specialty provider would get billed. So it's very straightforward. It usually includes seeing a provider like a nurse practitioner, a physician assistant, or physician. It may also include the support of a social worker or community liaison. The way that differs from hospice, as we already said, for an individual to qualify for hospice, they must have a prognosis or a life expectancy of 6 months or less. But if someone has that and they decide to elect their Medicare hospice benefit,
Yeah.
it also includes a lot of other support. So that support starts first and foremost with the entire team. So while you will be seeing a physician and potentially a social worker, the hospice team also includes a nurse case manager who helps kind of lead the plan of care and provide that ongoing support. It also includes a chaplain or spiritual counselor. It includes hospice care consultants. It includes hospice volunteers. The hospice team is a very large team, and it's designed to help bring quality care to an individual wherever they call home. Quite often, patients who are seeking out palliative care must go to a palliative care clinic, or they oftentimes will receive that support in a hospital setting. The hospice benefit is designed to bring the care to an individual wherever they call home. So quite often, patients receive hospice or quality end-of-life care at the place that they call home. That might be their private residence. It might be in a senior living community, like an assisted living or independent living, or even a skilled nursing facility, if an individual's care needs are that great that they require to be in that sort of place. So additionally, whereas, the palliative care specialty benefit might be something where an individual still has a copay, the Medicare hospice benefit is kind of looked at in the same way Medicare looks at Social Security. It's a federal entitlement. So it's one of the few things that Medicare covers at 100%. And so not only does it include a 100% payment for that entire care team we spoke of, like the nurse, the doctor, I forgot to mention the nurse's aide, social worker, chaplain, volunteers, and everyone else in between. It also pays at 100% all of the medical equipment someone would need to make sure that they had good, safe, quality care, and all of the medications they need related to their hospice care as well. So it's a much larger total benefit of care to support that individual at end of life. And I would like to take a moment real quickly to just define end of life.
Yeah.
Quite often, we'll talk with individuals or we'll talk with their family members and say, okay, we're not ready yet for hospice. And we always have to ask, well, what do you mean when you say you're not ready yet? And what does being ready look like? And quite often people are confused and think that, well, to qualify for hospice, someone needs to be in their final days or weeks of life. And we always like to make sure that we reinforce, as I mentioned earlier, it's a 6-month benefit. A patient qualifies for hospice as soon as their physician, in collaboration with the hospice physician, believe that an individual has that prognosis or life expectancy of 6 months or less. So quite often, what we hear from families after their loved one passes away on hospice with the support of the hospice team, and we're providing ongoing bereavement support, probably the number one piece of feedback that we get is we wish we would have done it sooner. And that's because quite often there's the key myth, the biggest myth of hospice is that when someone goes on hospice, it means they're giving up hope. And that's simply not the case.
Yeah.
When someone goes on hospice, the fact of the matter is that they're understanding that they're at a place that they're no longer going to benefit from curative treatment, and they now want to focus on comfort over cure. And simply what we're allowing and helping people to do is to redefine hope as it looks like given their current state of being and their healthcare needs. So the beautiful thing is that we're helping people redefine hope. And so what does redefined hope look like for a terminal cancer patient or an end-stage heart failure patient or anything in between, even an Alzheimer's or dementia patient? And what does hope look like for their family? Hope looks like comfort, peace, dignity, and respect at the end of their life. And it all starts with the basic premise that everyone dies, but not everyone dies well.
Really quickly, there's a couple questions mixed up there. Actually, the first basic question, I hope this doesn't come off crass because I've heard this as a joke, but does anyone come off of hospice care? Is that, or is it?
That's a great question. So we actually see in for our program here in St. Louis, roughly about 5 to 10% of our patients depending on their diagnosis, the reason why they're coming on hospice, and if they're put on hospice soon enough, sometimes patients experience such a dramatic improvement to their overall functional status and healthcare status that they actually graduate off hospice services.
That's
So,
really amazing.
yeah, it is amazing. So, probably the most common diagnosis that we see this happen with is with patients whose primary diagnosis is end stage heart failure. Quite often, through the course of our lives, we see a lot of specialties, specialists, and physicians and go to the hospital, and medicines just kind of get added on as we go throughout life's journey. So, because hospice takes a human centered, holistic approach to someone's care, we quite often add on new medications. We get rid of medications that we think aren't being helpful. And we really work collaboratively with an entire group of people to figure out how to meet this individual's needs. And so sometimes patients whose primary diagnosis is heart disease or heart failure can have an improvement in their functional status and actually eventually no longer qualify for the hospice benefit and graduate off services. Now, that isn't to say that they won't need us down the road,
Of course.
because we all know you can be the healthiest person in the world and you won't live forever, right?
Yeah.
At some point, the healthiest individual at 105, 110 will need the support of the hospice team. But it does happen. And the one unfortunate side of that is it's really hard for family members who've grown to love and appreciate the support of the hospice team to replicate that amount of services and support when someone does graduate off services. But the
Mm,
hospice team will typically work really hard to bring in other people and make other recommendations for care, and then continue to be available should something change and that individual need our care again. So patients can be discharged off hospice, whether they graduate, whether they say after a couple of weeks, you know what, I decided I'm not ready to go on hospice yet, and I want to focus on maybe a new type of chemo or something like that. So individuals have still have the autonomy to choose when and where and what kind of care they receive. And should someone change their mind or graduate off hospice services and then say 3 months down the road need us again, they are willing to come back onto services. There may just be a few extra hoops that we have to jump through for Medicare or the insurance to pay for it.
yeah. Uh, Actually, your last name actually brings up the next question. When someone goes on hospice care, does that I assume that means they're not receiving any curative thing, or they still could, but that's just not the focus, or
So there is the possibility that patients still could receive some curative treatment. So it's very individualized, right?
okay.
Because it would be a complete conflict of interest for, say, a cancer patient to say, okay, I'm going to go on hospice and I'm going to focus on comfort measures while also still receiving chemo and radiation, which actually help make a patient more uncomfortable,
Yeah.
right?
Yeah.
So, but there are some patients who have multiple chronic conditions or end stage diseases who could benefit from both. From a palliative standpoint, sometimes you might have a patient who needs to go in for a minor procedure to get fluid drained off their lungs or organs. And by doing that, they'll actually be more comfortable, which is the key component of hospice. So some patients may still benefit and qualify to receive both some curative treatment and some comfort measures, but it's usually on an individual basis, and how the individual's hospice team and their insurance maybe collaborate to work together on getting some of those things approved and paid for by Medicare or the other private insurance. It is interesting to see, though, that as Medicare Advantage plans continue to increase and are now the majority of all Medicare patients is a private Medicare insurance plan, is that these plans are actively working on creating pathways to what they call concurrent care models, which is where they allow patients based on diagnosis and their needs to have access to hospice care while still receiving some curative treatment. And we believe that's a beautiful thing because it will allow patients who qualify and would benefit from quality hospice or end of life care to receive that sooner, while also still receiving other care that they feel like could benefit them or that are in line with their personal goals.
Yeah. Okay. So thank you. Yeah, no, thank you for that. That was actually helpful. You can go back to your presentation.
Oh, sure, absolutely. So, I think, as we talked about recently, we just defined what hospice and palliative care are. We defined what constitutes those care models and what they look like. Oftentimes people ask me then, well, one of the kickbacks we might get is, okay, I understand that. I get that, hospice isn't giving up hope, but there's also the myth that hospice comes in and just takes away all the medications and starts giving narcotics, and that patients actually die sooner when they go on hospice. And there's actually a lot of studies that state the exact opposite. And there are plenty of studies, especially when it comes to heart failure patients, lung patient disease patients like COPD, or even dementia or Alzheimer's patients. And the average patient who elects hospice actually lives longer when they're on hospice compared to their counterparts or patients with similar conditions and diseases who never elect hospice. So not only does hospice help people have more dignity and comfort and support at end of life, quite often that relates into a more comfortable transition, which we're focusing on quality of life, helps people actually live longer. So hospice isn't just about dying well. Hospice is also about living well with the time you have left. And so quite often these patients who they get to enjoy the full benefit of the hospice team when they're identified and start services soon enough actually live longer as well. And in fact, some studies show that end-stage heart failure patients live as much as 3 months longer on hospice than their counterparts who never elect the hospice benefit. So these are all things that are really important. The other important conversation that my team quite often have is about code status, meaning does someone want to be a full code, meaning that if their heart were to stop, they would want full cardiopulmonary resuscitation, or would they transition over to being a do not resuscitate or a DNR? And this is oftentimes a very hard conversation because of that myth or misconception that if someone becomes a DNR, that one, they're also giving up hope, which is not true, or that if someone's a DNR, that the medical professionals won't do other things and still won't receive any treatment that still could benefit them, and that they would just be allowed to suffer. And again, as we discussed, the core tenet of palliative care and hospice is to treat suffering, to keep people comfortable, to reinstate dignity into the care model. So, that's definitely not the case. But also, some people believe that when they go on hospice, they have to go ahead and immediately sign a DNR if they're still a full code and still are requesting CPR. And that's not true either. We quite often have patients come onto our services and they still remain a full code. We understand that that's a process. No one just flips a switch and says, okay, I'm ready to stop everything and be a DNR. Coming to terms with one's own mortality is a process, not an epiphany. So yes, we oftentimes will help patients, but the main way we help patients is by having what we refer to as burden versus benefit discussions and conversations. And that is helping people understand that there are both benefits, but also burdens to receiving CPR, especially for the elderly. So as we look at whether it's an individual who still has full autonomy and can make their own decisions, but they're 85 years old and maybe just at the end of their life and experiencing multiple issues, or a family member who's looking at making that hard decision for their family members, there are some very important things to keep in mind. The first is that CPR wasn't designed with an 80 or 85-year-old individual in mind. It was designed for a 25 or 35-year-old individual in mind, someone who has experienced acute trauma or an incident like drowning, where there's meaningful hope for recovery and to quickly bring that person back to a baseline functional status. However, I must also say that CPR in real life is not what it looks like in movies or on television, where maybe the hero has some huge incident, has an accident, his heart stops beating, someone rushes to his side and starts pounding on his chest and says, we need you, we need you. And all of a sudden he sits up, gets back into the fight and saves the day. And that's just not how it works realistically. Most physicians would tell you that CPR, when done correctly, is actually more closely akin to bodily assault. For CPR to be done correctly, and I've had to help perform CPR in a hospital setting, quite often patients have their sternum or ribs broken. There is muscle and cartilage bruising, and oftentimes even organ damage caused by appropriate CPR when it's performed correctly. So if you think that those things can happen to, say, a healthy 35-year-old, it's even more detrimental and painful for an 80 or 85-year-old. So the statistics around CPR in the elderly are actually pretty staggering. And one statistic is that with individuals 68 years or older, who receive CPR and they have at least one chronic disease or condition like diabetes or heart failure or COPD, only about 15 to 20% of them are still alive 6 months after receiving CPR. When an individual is 80 years or older, that number declines to roughly 2.5% of all those individuals are still alive within 6 months after receiving CPR.
Yeah.
And so for many of those elderly individuals at the end of a long and hard life, depending on what diseases they have or chronic conditions they may be working through, for many of them, CPR is their final bodily experience. So their final moments are actually marked by pain and suffering of the weight of individuals performing CPR on them, which even for an unconscious individual can actually cause them to become conscious again as we start moving oxygenated blood back through their body and to their brain again. And patients actually wake up during CPR only to still succumb to their heart failure or cardiac arrest in their final moments, just maybe a few minutes later. So we really work very hard to help people understand that CPR isn't what it looks like in movies and on TV. And for many individuals at the end of a long life, depending on their diseases or chronic conditions, CPR isn't actually a good thing if you're wanting to focus on comfort and peace and dignity at the end of life. So that's always a good one too, that we really work through in making sure that people understand. So when you look at understanding what hospice is, oftentimes people then say, okay, well, how do we know when it's time to start hospice, right? Or maybe even someone goes to a physician and a physician says, well, my physician hasn't brought up hospice yet. Well, again, you have to remember our current healthcare system is designed with diseases, not people at its center. And we do a really good job training our physicians to treat and help people and to find a way to cure or make someone better, right? So that's why, too, if something were to ever happen and you were ever to be in a car accident or you were ever to be home and you were to go into cardiac arrest and your loved one were to call 911, the default premise our entire healthcare system works off of is that everyone would want everything done to keep them alive, which again makes sense. But at a certain point in our life, I know for me included, there will come a time where I would rather focus on comfort measures over curative measures because there is a benefit to one or the other, and there are burden or risks with one over the other. So it's very important that when we have those conversations as families, whether we're caring for our loved one or for spouses who are still supporting each other and living at home alone or whatever that looks like, that we have open and honest conversations about where we're at in that process. And I would encourage everyone to then also think about having an advanced directive or an advanced care plan. By having an advanced directive or care plan, we're documenting and sharing with our loved ones what care we would like to receive should a situation occur that we would be unable to tell people what care we would want in a traumatic or urgent event where we'd be taken to the hospital. And the hospital's default premise is, okay, we want to do CPR, we're going to do surgery, we're going to do this. But if you can say emphatically and have documentation to support it, actually, my loved one wouldn't want that. He or she clearly stated that if something like this were to occur, this is the care they would or would not want to receive. All those things ensure that someone gets the care they want in accordance with their wishes, even when they can't verbally express or tell a healthcare professional what those care desires or wishes are. And then additionally, it helps take a lot of burden or stress about what to do from the patient or family. Quite often, I've seen some pretty traumatic events where, say, an 85-year-old woman is in the hospital and she's in the ICU and she doesn't have a plan in place, or maybe hasn't talked to her family about what those decisions would look like and what she would want done. And then you start having family members like children and grandchildren start honestly having a little bit of a debate or a fight about what mom or grandma would have wanted. And what happens is it actually causes a lot of strife and turmoil for family and caregivers at the end of life. And so, unfortunately, you even see instances where family members are torn apart over discussion. And I've even heard comments like, well, I disagree with you. And if you want to let mom die, it's on you, right? Yeah. And that's a traumatic and tragic thing to happen when people have a legitimate disagreement about what's in the best interest of their loved one. And this is totally common and natural. Quite often, doctors will disagree on what the appropriate course of action is for an individual who shows up at a hospital and what they should be doing to support this individual. So that really reinforces the importance of what an advanced care plan or advanced directive is. And it's not about telling people what they should decide should be their care option. It's just advocating for the importance of writing it down,
Yeah.
talking about it with your physician, talking about it with your family, getting your your code status, your DNR, your plan of care authorized, maybe signed by a doctor, or even going and having it notarized so it becomes a legal binding document, and then sharing those documents with your loved one. And one of the beautiful things about it is whatever you decide is your advanced care plan today, you can always change tomorrow. So right now, my advanced care plan is I'm a full code, but there's also strict guidance in there that if I were to have no brain activity, what kind of care I would want to receive, or if there's meaningful recovery, if I'm ever in a coma, you can literally be that specific about it. And then if I were to change my mind about certain things down the road, I can always do that. So it's very important that you document the care you would want to receive, and then you'd be able to give that gift of pre-planning about your care to your family and loved ones. So when the time comes, the burden of making that decision does not fall on them. It does not create any strife, because everyone knows what your plan was, what you would have wanted. And all they have to do now is just honor and support your wishes. And that's a beautiful thing.
And I was actually there's a comment in the chat from our care manager Lee. She actually gave a presentation earlier this week on chaplaincy, and that was actually a big part of her presentation as well, because she's actually had to, as a chaplain, she's been the one in the middle of those fights a few times.
Yeah.
And so, well, actually, a quick note in case you don't have a chance. At least from my understanding, the hospitals in the St. Louis region, I assume universal, but at least St. Louis, chaplains, what did she say? Chaplains do have resources on advanced directives. For anyone watching, if you need some help, some guidance, they're trained to like help you think through and write this stuff. And
And I agree with that. Unfortunately, quite often, if we're having goals of care and advanced care planning conversations at the bedside in a hospital, we're probably a little too late.
Yeah.
So I would recommend to the listeners and watchers of this presentation to start having a conversation with your physician about having an advanced care plan if you don't already have one. You can also seek out an elder lawyer or attorney. You can even go, there are a lot of nonprofit resources here in St. Louis. So one form that we love to use, and that I actually use for my own advanced care plan, is the 5 Wishes book. And you can get them for free by going to 5wishes.org. And there's a very good comprehensive guide that spells all of the kind of different components of an advanced care plan out very plainly and easy to follow. There's also an amazing organization here in St. Louis called the Gateway End of Life Coalition. And they do amazing work and public presentations as well about helping people understand what an advanced care plan is, or even be able to complete their advanced care plans. So again, by understanding all of these things and what your care plan would be in advance, and ensuring your physician and your loved ones know what that is, you increase the likelihood of receiving care in accordance with your wishes. It keeps you in control of what your care plan and care journey would be, and also takes that burden of decision making away from your family and loved ones, and allows them to continue to be truly your support and your family versus your decision maker.
That actually I just had a thought, but I actually think it'd be too tangential. But I'm sorry. Continue.
Well, I think we've done a good job here over the last half hour defining hospice and palliative care, talking about how that differs from curative care models or the current disease-centered healthcare program. We've talked about the fact that hospice does not mean giving up hope; it's redefining hope. Just like whether or not you decide to be a full code and would want cardiopulmonary resuscitation, or whether you become a do not resuscitate or a DNR. And we've talked about the fact that, quite simply, patients benefit from hospice. If we all agreed to the simple premise that we're all born and one day we'll all die. And if everyone dies, and we can all agree that not everyone has a good death or dies well, this is something that we should all strive to look into about how we can support ourselves and each other at the end of life. And that is to reinstitute death with dignity, death with comfort and peace and respect. And quite often people think that, well, when a loved one goes on hospice, once they pass away, the hospice care team's support ends. But the hospice benefit actually includes over a year of ongoing bereavement and grief support to the loved ones of an individual who were involved in that person's care. So I know for my team here at Accent Care in St. Louis, we actually have amazing in-person grief support groups. We provide other resources and counseling. We also help connect individuals to any other options they may need. And so the care of the hospice team does not end when the individual passes away on hospice care. We continue to provide support and love to their family and their loved ones as well. So that way we ensure that we're coming through full circle. And not only being a healthcare professional, but having family who's been on hospice and actually currently have a grandfather on hospice in Ohio. I know firsthand that it's been an immense amount of support to my family to receive the care of the hospice team after my loved one passes away, and to know what that looks like as well. So again, in summary, I think the biggest thing that really hits home for me is that not only the feedback that I receive and my team receive here in St. Louis from family members when we're providing that support ongoing for over a year after their loved one passes away, but what the National Hospice and Palliative Care Organization, the number one feedback that they hear, and that they actually went to Congress 5 years ago and told them, is that the number one feedback we receive from families in meeting and conversing with them afterwards is, one, they truly appreciate the support of the hospice team and that they wish they would have done it sooner. And that is because, unfortunately, many people, while it's a 6-month benefit, don't access the benefit soon enough. And so about 1 in every 4 patients who goes on hospice is only on hospice for a week or less before they pass away. And the average amount of time that an individual is on hospice is only between 2 and 3 months of a 6-month benefit.
Yeah.
But that's also to let everyone know that, well, what if your loved one gets on hospice soon enough? What if we've done a really good job planning and we know when we want to make that transition? And as soon as they qualify, as soon as we ask their doctor, hey, what are we looking like here? What's my loved one's prognosis? What's my prognosis? What can I reasonably expect my life expectancy to be if my disease or my healthcare runs its natural course? And as soon as they say 6 months, you go, okay, I'm getting on hospice. Well, just because you may be on hospice for 6 months doesn't mean, well, at the end of 6 months, you get kicked off as well. There are some beautiful examples of individuals being on hospice for 9 months or even a year, right? So the help of the hospice team can be very instrumental and supportive and really be a beautiful addition to anyone's end of life experience. And as we defined earlier, that isn't the final hours or days or weeks, it's for the last months of life. So I would encourage anyone who feels like they're either at a place where maybe they're thinking about that for themselves, or they're caring for a loved one who they feel like may be nearing or at that place now where we're talking about months left. That I would encourage you to talk to your doctor or even reach out to a hospice team directly. Ask questions, learn everything you can about that hospice team, and see what the next steps are to start getting your loved one or yourself the care that they could benefit from.
And just to clarify one point, you mentioned, right, people have been on hospice care beyond 6 months. That's still covered by Medicare?
Yeah, so the way the Medicare hospice benefit works is every couple of months, the hospice team comes together, including the hospice physician, and reviews the case of that individual, their care plan, what's going on. Are they improving? Are they kind of stable right now? Are they continuing to decline and need additional support and help? And we do this as mandated by Medicare every 2 weeks. But every couple of months, a big part of that review is us taking a fresh look at this individual's care plan and their healthcare needs and saying, okay, starting today, maybe they've been on hospice for 3 months. But today, if I look at this individual and we assess this individual and we look at their needs, do we feel like starting today they have that prognosis or life expectancy of 6 months or less? If the answer is yes, then they're recertified for hospice eligibility and they continue to receive that care, and Medicare will continue to pay for it at 100% as long as our physician continues to believe that that person's prognosis is 6 months or less from the time of recertification.
Okay, that's a key point, right? Because I think a lot of times when we, at least for myself, it's easy to confuse eligibility with the the benefit itself, right?
Yeah,
So that's a clear distinction, right? You're
right. And
eligible for hospice at 6 months or less,
yeah,
but after that, it's as long as you still have that 6 months or less.
right. Right. And it's important to remember too that no doctor has a crystal ball.
Mhm.
So for instance, one of my grandfathers who is no longer with us, and he expired on hospice 9 years ago after his cancer battle. He was originally told when he was diagnosed with cancer that he had 2 to 3 months, right? Well, he actually lived 11 months,
Oh, wow.
right? But I've also heard the opposite, where someone's been told, hey, they have 6 to 9 months, and they only lived for 2 months after a life-limiting diagnosis or disease, right? So
Yeah.
no physician has a crystal ball, not even the best trained physicians. But what we do and what Medicare honors is a physician's best judgment. And that's why they always require, when someone originally goes on hospice, to have two physicians believe the same thing, that that individual qualifies for hospice based on that prognosis or life expectancy of 6 months or less. So it's usually like a patient's primary care doctor or a doctor at a hospital who's making the initial referral and writing the order for hospice. And then they collaborate with the hospice physician who also then substantiates or reviews the records and says, yes, I agree. And now this person is eligible for hospice. And if that individual or family member of that individual say, okay, we're ready to move forward, then they get admitted onto hospice services and the care begins immediately.
And that it sounded like a summary, but I don't want to cut you off. Are are you done with your presentation?
Yeah, absolutely. Well, and open it up to any questions you may have. But I think, hospice is a very complex, when we're talking about care, right?
Yeah.
Especially care at someone's end of life, that's a very long and involved process. So, by all means, I would love if people planned ahead, if they really took care and considering what their options are. But I think we've done a good job today in kind of summarizing it in a quick nutshell. Even though we could talk about this for hours, I know that we won't burden everyone with that. As you know, I understand more importantly, and I think many of your audience members will too. Talking about death and dying isn't always the most enjoyable or comfortable thing to do.
Yeah.
It's kind of like talking about religion or politics with family members around the holidays, right?
Yeah. Yeah. Yeah.
But it's necessary. And the way we make it easier is by normalizing the conversation, by just having simple conversations now about what care someone would want to have at end of life, when they would want to be on hospice, what do they know about hospice,
Yeah.
what do they know about the burden versus benefit of CPR, right? And I think the more we normalize these conversations and we don't avoid them, the more likely it is that we'll all receive care in accordance with our wishes and that we'll all have a good, dignified, peaceful, and respectful end of life experience.
Well, thank you so much, Joshua, for your time. This has been really informative, and I wish my brain never works in the morning, but I always have these in the morning. I don't have a better adjective, but thank you for your time. Truly, uh, not just for myself, as I mentioned, I'm not very familiar with palliative or hospice care, but but I imagine this is really helpful hopefully helpful for a lot of our audience members who I think, like myself, probably aren't super familiar with hospice and palliative care, and there are a lot of nuances, and especially I think among many of the insights, I think I know if I was had a family member I was caring for, a big key takeaway for me is knowing that the 6 month benefit, that it's about eligibility, that's covered completely.
Yeah.
Uh, and also understanding that it's really a holistic care. It's not trying to end anyone's life, that it usually helps extend life. That was actually really don't want to be corny, but beautiful to like understand how
I was thinking the exact same word. Beautiful is right. I mean, again, we often hear the expression when it comes to raising children, right? It takes a village. Oh, it takes a village to raise a family and to raise children. And I believe too, it takes a village to help someone have a good death.
Yeah.
And that might seem like a really stark way of putting it, but again, not everyone gets to experience that. So it's a beautiful thing. So if anyone would ever be interested in learning more, they can definitely go to our website at accentcare.com. They can reach out and look up the Gateway End of Life Coalition, which is a nonprofit here in St. Louis that does amazing work. And again, if they're looking up resources around advanced care planning, I would suggest going to fivewishes.org, or even reaching out to their physician or an elder attorney or someone else who has a lot of experience in helping guide individuals on making these necessary plans to ensure that they're receiving care in accordance to their wishes and taking that burden off their family.
And I'll make sure to have all the resources that Joshua just mentioned up on the comments on Facebook underneath this video. All right. Thank you again, Joshua.
Thank you very much. I appreciate the opportunity. And again, I hope this helped anyone better understand their options at the end of life.
All right. Bye, everyone.